Good afternoon. Let's dive in. I know we have a hard stop at 12:50 since students will start class again at 1. So we want to make sure we give enough time to Dr. Nelson for his presentation and to all of you for discussion. So welcome to our Grand Rounds session today, January 11th. It's a pleasure to see you all. My name's Allison Tatarski. I'm the director of the Malaria Elimination Initiative here at IGHS, and we'll be facilitating this Grand Rounds today. We have our guest, Dr. Eric Nilsson, visiting us. Unfortunately, we were all meant to be in the same room together, but due to our crazy Bay Area weather this week, we were asked to stay home. So here we are back on Zoom. But thank you, Dr. Nilsson, for being with us. The title of Dr. Nelson's talk today is MotoMeds, a pediatric telemedicine and medication delivery service at night in Haiti. So a bit about Dr. Nelson. So Dr. Nelson is a physician scientist who studies pathways to better respond to large-scale infectious disease outbreaks using cholera as a model system. Over his career, he has expanded the scope of his research to design and evaluate novel approaches to improve healthcare access during and between infectious disease outbreaks. He draws on technological, medical, and scientific skill sets. In this presentation, Dr. Nelson will share the marriage of pediatric telemedicine with medication delivery in a service called MotoMeds in Haiti. The objective of MotoMeds is to address a common need that families need both clinical recommendations and medication in hand to avert emergencies, especially for those isolated by poverty and geography. In this seminar, Dr. Nelson will share findings from 4 clinical studies, a network analysis to identify healthcare access points, development and evaluation of a pediatric telemedicine guideline, scaling of MotoMeds during crisis, and digitization of the guideline as a key step to sustainability and scalability. So Dr. Nelson, we're really pleased to have you here. And we also have with us Maha Zubaidi, who's a student of the IGHS MS program, and Maha will facilitate the question answer session for us at the end. Maha is a student of the MS program as well as a medical student at Stanford University School of Medicine. Maha has special interest in mental health and more specifically the health of Palestinian people living under Israeli occupation. She plans to research mental health effects of frequent tear gas exposure in Palestinian children in the West Bank as part of her master's studies before completing her final year of medical school and pursuing a residency in psychiatry. So we're looking forward to hearing from you in the question answer session, Maha, later in our time together. But for now, I will turn it over to Dr. Nelson for your presentation. Thank you. Looking forward to it.
Great. Thanks, Allison. It's a pleasure to be here, and I'm broadcasting from Jaime's desk. So it's a pleasure to be here physically, and I hope you all are staying dry and warm in the rainstorm today. And just to double check audio and visual, Allison, can you see my slides and can you hear my voice okay?
Yes. All looks and sounds good, thanks.
So as Allison had said, the title of my talk today is MotoMeds, a pediatric telemedicine and medication delivery service at night in Haiti. I don't have any conflicts of interest or disclosures to make today. And I'll go just a little bit farther into kind of what we do at the Emerging Pathogens Institute, which is my home back at the University of Florida. So my job is to think about how to do better at large-scale outbreak response. And as mentioned, that involves using cholera as a model system. As we approach this task, I want you to reflect on the following statement. To improve an outbreak response, consider first the totality of challenges faced during the patient's journey. And what I mean by that is that our lab is a bit different from other labs in that we really think about the mission of improving outbreak response. And we view the arc of an outbreak response and identify the pain points in that arc of response, and then recruit skill sets to our lab to address those pain points. And it creates a very special, very diverse environment of talents that's very mission focused. So in the case of cholera, the journey really begins at home, early in disease when symptoms first start and people need access to knowledge and, in this case, oral rehydration solution in hand. As the journey moves forward at the clinic or the hospital level, there's gaps in our abilities to do triage, diagnosis, rehydration, and therapy, being antimicrobials, efficiently and effectively in large-scale outbreak response. And then the third piece is at the community level is how do we pull forward these data and observations such that policymakers can take action at the community and public health level. So within our lab, our work manifests in various bins. At the implementation telemedicine side, that's what I'll be presenting today. We have a recent publication in Journal of Pediatrics that highlights some of the points I'll be sharing with you. At the point of triage, over the last few years, we've been digitizing the WHO guidelines for diarrheal disease management. And that work has shown both the strengths and weaknesses of digital tools in a resource-limited space. When it comes to diagnosis, I've been collaborating with a colleague, Daniel Young, at the University of Utah. And part of Daniel's talents is that he has this team that can think about how do we bring together informatics, AI-enabled tools, in this case, to make a prediction that a patient has viral disease alone versus other being bacterial disease. And then how does that knowledge inform clinical behavior on using an antibiotic or not using an antibiotic? Even with those tools now at hand, there's still a need for point-of-care diagnostics. And we've, in our wet lab, have researched some of the reasons why point-of-care diagnostics, in this case for cholera, are limited because of prior exposure to antibiotics or a predation by vibriophage that eat the cholera, and so the diagnostics may fail. And what we're doing is we're having addressed those limitations and put a name to them, we now can iterate point-of-care diagnostics to make more durable diagnostics. When it comes to rehydration, the WHO guidelines are not as evidence-based as you may think. And so a colleague of mine, Adam Levine, has been doing a series of clinical studies to make a new algorithm for assessing dehydration for kids under 5, as well as kids 5 and above and adults. And we work with them to take those algorithms, put them in the digital tools, and then look to see how they perform at the bedside. When it comes to antimicrobials, there is a need to risk stratify patients on the potential of them having antimicrobial resistant organisms. This is, again, a collaboration with Daniel Young. And what we're doing in the laboratory is complementing that work to look at what are the assays that we use to assess antimicrobial resistance. How can we rethink those assays in such a way that we can discover new mechanisms of antimicrobial resistance and then inform guidelines in terms of which of the recommended drugs we should actually use for therapy, but also potentially for prophylaxis. Now, luckily, I have the honor of sitting with the World Health Organization in a group called the Global Task Force for Cholera Control. And this allows me to convey these kind of bins of discovery and insight with the WHO, so then they can manifest in policy change that's both global, but then also can engage with ministries of health around the world. So today, as I mentioned, we're going to start with this first effort, which is really at the very beginning of disease. So for those students on the call today, there's 4 learning objectives that I have for you. From a pediatrics perspective, the objective is to know the leading causes of pediatric morbidity and mortality globally. The second is to understand barriers to accessing healthcare from a health equity perspective. From a healthcare delivery, to explore emerging approaches to overcome these barriers. And number 4, from a healthcare research perspective, appreciate the value and impact of a cross-disciplinary team. So we're going to begin with United Nations Sustainable Development Goal number 3.8, and this is to achieve universal healthcare. This is important because more than half of the 5.3 million deaths among children under 5 years of age, these could be avoided with basic access to healthcare. When we look at the performance on reaching this goal, it's a bit sobering. So over the last 30 years, this graph shows our progress towards universal coverage. You'll see almost a flat line with a slight upslope that dips in the COVID-19 era. So what this says to me is that using the same approach that we've had over the last 30 years is not making much gain. And so we need to bring innovative strategies to the table that might involve community healthcare worker models. It might involve the initiative I'm sharing with you today, but we need to think outside the box. When it comes to the reasons why kids die under 5 years of age, this is a publication from the Global Burden of Disease that looks at under 5 mortality. And it's shown in the yellow wedges are the reasons why neonates, kids under 1 month of age, die. In the leftward side are reasons for death from 1 month to 5 years. And there are 2 wedges here that are of particular interest. Lower respiratory tract infections represent 10%, diarrhea is 8.5%, and the malaria is 7.8% as the third wedge. And definitely for LRIs and diarrhea, there are known, effective, and low-cost therapies to prevent death from these illnesses. And the charge that we really have is, if that's true, then how do we get access to these elements so that the kids can avert mortality? And so it's really an access to care challenge rather than should we use amoxicillin or not, or should we use ORS or not? So that's part of the challenge that brings me to the table today. So we're going to focus on that upstream portion of the mission of our lab. I want to point out an award that our director in Haiti, Molly Klarman, received from ASTMH as a second place prize for innovation in global health 2 years back. I also want to say thanks to a colleague, Jason Friesen, who's the founder and CEO of a company called TrekMedics. It's an NGO that builds EMS software for diverse settings, including places like Haiti. So I'll begin with a quote from Albert Einstein, which is, "The significant problems we face cannot be solved at the same level of thinking we were at when we created them." So within this research initiative called MotoMeds, we believe in making early access to healthcare available for all children. We do this by combining eloquent clinical guidelines, durable technology, and human-centered design to make solutions that are desired, feasible, and viable. We work in some of the most challenging settings in the world, and the solution I'm sharing with you today, again, is called MotoMeds. Our challenge is, how do we provide children like this early access to high-quality pre-emergency care to avert an emergency? We use a process that you're probably quite familiar with called human-centered design. Groupido.org is located right up the street. And their initiative comes in 3 segments: a hearing phase, a creating phase, and a delivery phase. And on the y-axis, it moves from a phase of concrete thinking to abstract thinking and back to concrete thinking. And then it takes a journey that begins with observations that identify stories. These stories coalesce around themes. These themes identify opportunities, and from these opportunities, solutions may emerge that can be prototyped and implemented. Successful products are those that are desired by the end user, feasible, and viable. So this takes us to Haiti, where we wanted to conduct a needs assessment to really understand at the basic level the needs of communities outside of Port-au-Prince. And to do this, we wanted to gather stories on barriers to accessing care without bias to assure that voices were heard equitably. And my colleague Stace Maples from Stanford is on the call today. And what he helped us do was think about this sampling bias that often occurs by road biases. And so we set about establishing a study area. Within that study area, we divided it up into 2x2 kilometer grid cells. We stratified them by population density. And then based on the number of surveys that we were going to conduct per grid cell, we dropped that number of pins into a grid cell, demarcated them with Thesian polygons shown on the rightward side. And then we used software from Esri to walk our team into those polygons to conduct a survey and ultimately avoid row bias, as you can see by this road that's curving through the rightward panel. And in the survey that we conducted, we asked 2 basic questions, which was, if your child had respiratory disease or diarrheal disease at 2 in the morning tonight, and they feel ill, what is your intention? What would you do to seek care, and from whom? The second question was, in the last 28 days, did anyone fall sick in your household, and who did you seek care from? And so when we conducted the survey, providers that were named, we went to those providers and then gathered stories from their perspective about the households that sought care from them, but then also the providers that they referred cases to. So this was really building a healthcare social network. And I'm going to show you the data that came out of this study, in which the salmon-colored circles are households, the dark blue circles are conventional providers, and the light blue circles are non-conventional providers. And the leftward side is the intention. What would people do? And what you see for both the standardized respiratory and diarrhea cases, most households preferred to seek care from one of two providers, H1 and C1. But when you queried them on what they actually did, what their behavior was, you see a more disorganized network such that fewer people actually sought care from C1 and H1. And there's a higher number of providers that includes non-conventional providers that care was sought from. So with these analyses, and this was published by Molly Klarman and Justin Schoen in BMJ Open, we identified a theme, which is that families face barriers accessing their intended provider. And those barriers are represented by this red bar, and those include poverty, geographic isolation, and multiple factors, including nighttime presentation of illness. So then an opportunity arose, which was, how might we bypass these barriers? And as we thought about solutions, we had a few criteria. The first was that we needed to provide timely access to both knowledge in mind as well as medication in hand. And what I mean by that is that healthcare systems are good at providing 8 hours of daytime care. However, this leaves 16 hours in which vulnerable patients may face gaps in care. These gaps are dangerous for children who can rapidly progress to life-threatening illness, and they need in those 16 hours that access to both knowledge and medication. The second stems from my work with cholera, which is that the solution must be durable during acute crisis. And shown here are images of a gentleman from Bangladesh, Zimbabwe, and Haiti, in which these individuals developed cholera symptoms at night, didn't have access to ORS, progressed to severe dehydration, and showed up in shock at the clinic in the morning, which would be avertable had they had access to both knowledge and ORS. The solution must also address barriers during chronic crisis. This is design work in Bangladesh, and here communities face chronic, severe poverty. There are effects of climate change. There are many barriers that are chronic, and a solution would need to be durable in the setting as well. So from multiple years of design work, we eventually landed on this idea of a telemedicine and medication delivery service to be that bypass. And today we're going to share the story of how MotoMeds was built, how we've worked to validate it, but then also in the discussion, maybe we can explore where it will go in the future. So when we began, and I should say that I spoke at Global Health Grand Rounds in 2018 here at UCSF, and we were in the formative phases. Shortly thereafter, our strategic plan formalized, and it really centered around a guiding hypothesis, which was when resources are limited, morbidity and mortality can be effectively reduced at lower cost by facilitating early access to pre-emergency care compared to late access to emergency care alone, especially at night. So we framed the Improving Nighttime Access to Care and Treatment studies, called ENACT, that were in 4 clinical studies. The first was the needs assessment that I mentioned earlier. And then I'm going to take you through 3 studies, a pre-pilot of a MotoMeds prototype that focuses on safety, feasibility, and desirability. ENACT 3, which is a pilot of the scale MotoMeds model, again focusing on safety, feasibility, and desirability. And ENACT 4, which is a scaled deployment of the MotoMeds model with digital decision support to really focus on that more viability component of the initiative. There are many challenges in Haiti. And here are 3 news articles from this past year. Gangs advance on the seat of Haitian government power Haitians are hostages. Fuel hike plunges Haiti into near anarchy. Gang warfare cripples Haiti's fight against cholera. Now, these are real and very serious challenges, but I tend to be positive in mindset, and I also view Haiti as a setting that has an opportunity that if you can build something in Haiti, and if it can sustain and be durable with all of these challenges, not only will it be well designed for Haiti, but it'll be durable for portability globally. So going into the NAC 2 study, I want you to work on this conceptual model for accessing care. In the classical emergency medical service model, the EMS model, ambulances or vehicles of your choosing bring households to centralized resources. But what we're proposing of MotoMeds is to mobilize centralized resources via motorcycle from a central location outwards to a household. So the NAC 2 study had two objectives. Number one was safety. The idea was to develop a first of its kind pediatric telemedicine guideline and validate it by comparing what we hear at the call center with what we see at the household with an in-person exam. So in this study, all of the calls that were enrolled, if they lived in our delivery zone, a nurse went on that vehicle and had a paired exam as a reference standard. From a feasibility standpoint, we wanted to see if we could invert this EMS workflow to enable a telemedicine consult and medication delivery service in which we could access households in under 2 hours for pre-emergency patients in something that we empirically call the silver 2 hours. And that's where my colleague Jason Friesen comes in, because he had built software for a classical EMS model, and then we asked him, could we flip it upside down and use it for delivery? So the wireframe for how MotoMeds generally works is that patients under 10 years of age, their families call in on their behalf. They get triaged using WHO danger signs. If they have a severe life-threatening condition, they bypass MotoMeds and go to a hospital. If they're not considered life-threatening at that stage, they go through further triage, assessment, and a plan is generated. And then there's a question of, do they need medications or fluids at home? If so, they'll route downwards and receive that delivery. In the context of the NAC 2 study, they also had a nurse on those vehicles. If they live outside the delivery zone, or for whatever reason, refuse a delivery or need advice alone, the consult is all that they'll receive. All participants enrolled receive a 10-day follow-up call to assess their clinical status. So in the NAC 2 study, from September 9th, 2019 to January 17th, 2021, we had roughly 3,200 contacts. Of these, 500 were on operational hours, 391 were enrolled. And then within this, 347 had paired virtual and in-person exams. We were able to follow up on 90% of those. And then 44 patients didn't have that in-person encounter, and we were able to follow up with all 10 of those. So with those data in hand, let's look at some of the feasibility and operational metrics. So our call length was 20 minutes, delivery time was 80 minutes. Intended deliveries completed was 347 or 98%, and our follow-up rate was around 92%. Looking at the clinical, also on the logistical side, for those that haven't been to Haiti or haven't worked in settings like this, I want to impress upon people that there are no paved roads in Haiti. There are some main arteries that are paved, but where we work, most of the roads are unpaved. There's no addresses and there's no streetlights. So to operate and hit that mark of delivery under 2 hours, it requires a very special ingredient, which is a very granular knowledge of the roads and the communities by our local pools of drivers and the nurses. And just to give you a perspective of that, I'm going to show a video of what it's like to do a delivery at night. Hopefully that video gives you a sense of the logistics of what we're trying to pull off. From a clinical perspective, the distributions of chief complaints were what we anticipated, led by fever, respiratory, skin problems, and diarrhea and vomiting cases. In terms of an illustration of how we leverage that virtual exam at the call center in an in-person exam, I'll just highlight that sensitivity and specificity for subjective fever reported at the call center compared to the measurement at the household was 91% and 69% respectively. In terms of severity distribution, 83% of our cases at the call center were considered mild, 11% were considered moderate, and 6% were considered severe. So those red ones bypass MotoMeds and go to the hospital. When we go to the household, where we anticipate all the cases to either be mild or moderate, what we found was the following distribution. 91% were mild, 7% were moderate, and 2%, or 1 out of 50, were considered to be severe from either a clinical or sometimes a logistical reason. In terms of clinical status at 10 days, if you add improved and fully recovered, that makes 95% of cases were doing better than they were at the time that we saw them. So with that initial pre-pilot study, we felt like it was time to pivot towards a more scalable model of MotoMeds in this study called ENACT 3. In this case, we recognize that in the ENACT 2 study, we were having nurses go to all the households. So what we wanted to test was an aspect of safety. If safety can be maintained when mild cases receive a medication and consult alone without a nurse visit, and moderate cases receive medication and consult with a nurse visit, meaning that this study was to remove a nurse going to the household from roughly 4/5 of the cases. So we launched the study in the community of Grecier, and shortly thereafter, there was an earthquake in the southern part of the country and included this city called Okai, which is the 3rd largest city in Haiti. And we had this moral dilemma, which is that we were positioned to provide nighttime access to care to this community. We didn't necessarily have the resources to do so, but what we knew what would happen was that first responders would go in for the first month or two, respond, and then pull out, leaving a gap of access to healthcare. So with partnership from Trek Medics and some philanthropy from Cisco Systems, we gathered the resources to do the deployment. And what we did was we took a step towards scalability, which is we went from a hub and 1-spoke model, being our community in Grecier, to now a hub and 2-spoke model, being Grecier and Okai. This represents an expansion that now covers around 6% of the country, or around 600,000 or 700,000 people in these two areas. So it was a big jump. From a logistical perspective, it involves families from Okai calling into our call center, that call center going through the triage assessment and plan. And then if a nurse is needed to go, the nurses in Okai have mobile pharmacy backpacks. They're contacted, they coordinate with the driver, and they go to the household. So this study ended in September of this past fall, 2022, and we're just gathering those data. But roughly we had 3,900 contacts, 1,200 were on operational hours. We enrolled just under 1,200, 1,200 contacted our service, 1,100 received service, and then just under 1,100 were enrolled. Now we've been the data in the 3 groups: cases receiving a provider visit, roughly 18% or 1/5, cases receiving a delivery alone, or cases that received a consult alone represents around 4/5. So our prediction of the distribution of cases turned out to be about right, where we could take the nurse off of 4/5 of the vehicles. And then in terms of clinical status at 10 days, 90% were recovered or improved. So unintended benefits have emerged throughout this journey. One is very much so intangible, which is this idea of hope, that someone, for the first time in one's life, places a call and answers and there's someone there to answer that phone. And with all the many challenges in Haiti, this idea that someone will answer your call for help is a very powerful benefit that MotoMeds is providing. From a capacity building standpoint, we have 10 call center providers, 8 on-call providers, 15 MotoMeds drivers, 1 research coordinator, and then 2 primary on-call physicians, and then 1 secondary on-call physician. So now I want to pivot to the future and think about next steps. Because we do face challenges when it comes to scaling and reaching viability, in that training new providers is time and resource intensive. And inappropriate guideline deviations do occur, incomplete documentation occurs, call duration remains long, and portability of the model is largely unknown. So to address these components, we have 2 parallel studies in play right now. The first is digitizing our clinical decision support tools. And we're running a pre-post study where we're going to run 6 months on paper and then 6 months with our digital tools to look at outcomes of guideline adherence, call duration, and time to delivery. And that's led by Molly Klarman and Yuslin Kajuzma in Haiti. Now, in Ghana, a team led by Torben Becker, who's an adult intensivist and ED doctor at the University of Florida, and Katie Flaherty, who's an MD PhD student in Florida, they're working with the Ministry of Health in Ghana to do a portability check for MotoMeds in an Act 2 kind of mindset in the community of Ushertown in Accra, Ghana. So for those on the call that do software development, we adhere to Steve Jobs' principle that simplicity is the ultimate sophistication. And I'm not going to walk through this wireframe diagram of how we're building the software, but the guiding principle is that we're not trying to accomplish everything with the software. We're trying to address between 90 and 95% of the calls. We've taken all of pediatrics, binned them into 6 chief complaints, where chief complaint number 7 is other. And we're trying to address the majority of cases, knowing that there's going to be cases that fall outside of our guidelines, and that with physician consult, we can address those cases. When it comes to the ENACT 2G study, looking at portability, Katie's completed a needs assessment in Ghana that was similar to the one that we did in Haiti. And now she's launched the pre-pilot of MotoMeds. And key points to think about in comparing these 2 venues is that Haiti is in the Caribbean, has limited EMS access. There's a low burden of malaria. And then on the Ghanaian side, it's in sub-Saharan Africa. There's a national EMS service that we're engaged with, and there's a high burden of malaria. Commonalities are that they're both LMIC, the populations are young, and that despite having a national EMS service in Ghana, there's still limited access to nighttime care. So in summary, I've shared with you 4 studies looking at need, feasibility in a pre-pilot, feasibility, and piloted mode, and now expanding onwards to viability. And then for those that might have joined late, I just want to share with you that, again, we believe in making early access to healthcare available for all children. We do this by combining eloquent clinical guidelines, durable technology, and human-centered design to make solutions that are desired, feasible, and viable. This has manifested in MotoMeds. As I just shared with you, we launched in Ghana. We're testing portability. Sorry, we launched in Haiti. We're testing portability in Ghana. And then we're exploring strategies on expanding in Haiti, expanding in Ghana, or maybe even branching more globally. And I'll end with a quote from a book I just started reading yesterday that's penned by Jane Goodall, which is, "Hope is what enables us to keep going in the face of adversity. It is what we desire to happen, but we must be prepared to work hard to make it so." I want to thank the teams in Grecier, as shown in this image. I want to thank the courageous team in Okai that expanded MotoMeds right after an earthquake affected their community. I also want to thank the teams in Ghana that just launched MotoMeds. And then this is a fun acknowledgement slide, because over the years, There's more and more names that have landed on the slide, and the font's getting smaller and smaller. But I do want to acknowledge our partners at the College of Medicine in Port-au-Prince, Trek Medics, run by Jason Friesen, shown here, our partner Christianville, that has the land by which we host our call center, our clinical lead, Chantal Baril, in Port-au-Prince, Yuseline Kajuzma is shown here, who runs the call center on a daily basis, Dr. Bojer in Okai, who joined to be a clinical consult, Ben Brintz, who helps on the software development, as well as some of the AI work, and our colleagues in Hyderabad at Beehive that help us build the software, administrative support at the University of Florida, and initial funding from the National Institutes of Health, and current funding from Children's Miracle Network, and private donations that have really been the player that made this recent study fly, and then USAID that's supporting the Ghanaian initiative. So I ask of you all to share the story, contact us if you have questions, and if I can't answer your question, my travel companion, Bun Bun, will be happy to answer questions that you may have. Thank you.
Bun Bun, who loves carrots.
Yes.
Excellent, excellent. Thank you so much, Dr. Nelson, for that fantastic, really super interesting presentation. I love how you work at the intersection of your interests of pediatrics and cholera. I love your sort of the very phased research approach you've taken, the design that really underscores your whole approach. It's really impressive and inspiring. So thank you so much for sharing this story with us. I know it's just a snapshot of the work that you do in the world. So very impressive, and thank you. So there's some fantastic questions coming in through the Q&A. Maha, if you'd like to come on video, we'll start with you and a couple of the questions that you had for Dr. Nelson, and then we'll open it up to the rest of the participants. So for all of those of you on the line, please, if you do have questions, feel free to put those into the Q&A at the bottom of your screen. And just so you know, Dr. Nelson, in terms of the participants who have flowed in over the course of your presentation, we have representatives from a number of our initiatives, faculty and staff, from our Center on Pandemic Preparedness. We have faculty and staff from our Global Strategic Information Center, from Malaria Elimination Initiative, and others, in addition to our students. So Maha, over to you.
Thank you so much for your very enjoyable talk, Dr. Nelson. My first question for you is something that you actually have already spoken about during your presentation, but perhaps you could elaborate on any future challenges you anticipate in sustainability and also reproducibility of MotoMeds.
Sure. So I think probably many of us face this challenge, which is there's research that's not implementation science. There's implementation science, and then there's a graduation of what we do in academia to implementation partners that might be NGOs, that might be ministries of health. And what we do on the research side is expensive and is not sustainable. The other thing is that from a financial sustainability standpoint, we are providing a service to some of the most marginalized people in the world. And so you're not going to have a financial sustainability model if you're asking them to pay for the service. So I think that in our current model, we will have a tripartite, which is a donor model, a Ministry of Health model, and then a patient component. And I will say that we have two parallel models at play right now. The one in Haiti is that we have a 500 good fee for accessing the service that's on a sliding scale to 0. Initially, we had about 50 or 60% payment towards that fee, but either the word is out that we'll waive that fee, or that things have gotten so dire that people just really have 0 funds to pay for things in Haiti. In Ghana, we're working with the Ministry of Health, and so as part of their bylaws, they provide free care. And so the model in Accra is a free care model that's testing other aspects of this. So my first goal is to build a clinical guideline that's evidence-based and share the logistical operation for other people to emulate. In terms of it graduating beyond academia, that's part of my mission here in the Bay Area this week.
Thank you. My next question is, you mentioned towards the beginning of your talk that Haiti is currently experiencing many forms of conflict. So what challenges did you face, or can you speak a little bit about how you ran those trials in Haiti?
That's a great question and a very timely question. Before I answer that question, I'm just going to point here to this exploratory cost-effective analysis that Katie Flaherty did, which looks at both the DALYs as well as the kind of per patient cost for MotoMeds, if you want to dive into that. To answer your question about challenges, there are many. And we have had only a handful of safety issues with our staff going out at nighttime. When we first started, I didn't sleep for a few weeks because I didn't know what the safety issues would be. But in all the 3 years that we've been running, we've stayed online nightly with very little disruption. We have had a staff member bitten by a dog. That's the most severe situation that we've had. And we don't take light of that because rabies is quite high in Haiti. Because often the last 3 years, armed roadblocks have taken place during the daytime, the people with the guns often go home at night to their families. And so literally at night, we drive over those roadblocks and make care happen at night in actually a safer way than in-person clinics can offer during the day. Now, the third piece is at the clinical level, and we rely on hospitals to refer cases to. And we can't assume that those hospitals will be staffed with people with pediatric expertise, that they'll be open, and that they'll have fuel. And so we had our second severe adverse event, which was mortality right before Christmas. We had one in the ENACT 2 study. We didn't have a severe adverse event in our ENACT 3, but now in this ENACT 4, we just had one. And in that case, our team adhered to the guidelines. They assessed the patient with a respiratory illness that was considered to be not severe. They followed that up the next day at an in-person clinic, and again, were considered to be not severe. The next day, their clinical status turned. They sought care at a hospital. They were put on oxygen. And about day 3 of that journey, the hospital ran out of fuel, the oxygen system failed, and the child died. So that is a very sad story. It speaks to the very desperate situation that Haiti's in, but it also speaks to the importance of us getting to households early, because downstream, the hospitals might actually not be equipped to deal with true emergencies.
Thank you so much, Dr. Nelson. Thank you, Maha, for those great questions. We do just have a few minutes left with our stop at 12:50. So I want to get to a few of the questions in the Q&A. So, well, first a comment from Dr. Carpenter, who's the director of our master's program, who just reflects that this is very inspiring. He's worked closely with the Clinic for Pediatric Chronic Diseases outside Port-au-Prince, and they've had 14 deaths over the past four years due to inability of patients to get to the clinic to access insulin. This model is wonderful. So hopefully you can pick up on that discussion together about your sort of joint experiences in Haiti.
And I'll just
Yes,
add
please.
that if people want to connect by Zoom next week when I'm back in Florida, I definitely can field some in-person calls or virtual calls.
Awesome. Thank you. So I'll go to Michelle Mogadassi, who's our informatics program manager, who asks about the digitization of the WHO guidelines. Will this move towards SMART guidelines? If so, can you describe the process or current status?
So that's a great question. So right now what we're building is basically a static guideline, and that will basically be a vehicle that in time can be more responsive to time and place. So the first thing is validating our paper guideline with these paired exams, and then digitizing that, running it, and then in time we can make it dynamic. And we have a paper in JAMA Peds that looks at a dynamic tool that looks at time, space, climatic events to inform some clinical decision making. That's kind of where we need to go, but we're definitely not there now.
Okay, thank you. And two sort of questions and reflections from members of our IGHS leadership. So first from Dr. George Rutherford, who says, truly admirable work. I'm delighted to see how it's progressed. Have you considered using these encounters to deliver preventative care like immunizations? And a follow-up question from George is, are the motorcycle drivers required to wear helmets? The drivers and nurses must be resources to be protected.
Yeah, so we have quite we call it in-depth safety plan for not only how we operate, but then also the safety of the motorcycles, the yellow vest they wear, the red helmets that they wear. There's an active safety plan, and we actually review that weekly and adjust given the situation in Haiti. I wish, George, that you were on my Gates Grand Challenge review panel, because I keep throwing an application that we can do such things as pneumococcal vaccination on site. And about 30% of our cases that have acute respiratory infection have pneumococcus because they don't have pneumococcus vaccine. So we hand out a lot of amoxicillin, and we could decrease those rates if we could get pneumococcus out to the communities through things like MotoMeds. Great
Awesome.
question.
Thank you. And from Dr. Eric Gooseby, thank you for your interesting talk and the important work. Following the Haiti earthquake, USG-funded programs were the core of the response for the first 6 months and remain the primary providers of care for the years following. The inability of the government to take control of management and oversight of the program precluded a handoff. Multinational NGOs do not have the ability to take it to scale, usually focused on small segments of neighborhood populations. So this, I think, relates to his concern around scalability and sustainability. Do you see your ability to move to scale being done by the government of Haiti or continued with a multinational NGO? And you sort of referred to this earlier in your response to Maha's question around sustainability, but I don't know if you want to add to that.
Yeah, so in Ghana, we're integrated right in with the National Ambulance Service, and they've really embraced it. So that's one model that I think is going to fly well. I have been very frustrated in an inability to spark meaningful conversation with embassies, U.S. embassies, and USAID. I've had very nice conversations with MSF, Save the Children, but there seems to be a hesitancy to take on this as a test of innovation, that it seems like people are burdened with what they have in hand right now, and they don't want to add a new problem and a new innovation to it. So that's frustrating. I think what we want to do right now is basically put MotoMeds into a nice package in a box that goes to the shelf in Geneva. And then when a Ministry of Health or a partner says, look, we have a problem providing access of care through the 16 hours overnight, what solutions do you have? You could take that off the shelf, you could localize it, and then it could be embraced and employed by those partners. That's sort of where I'm headed, and I hope we get there.
I think there would be a lot of access partners around the world who would be interested in that. So thank you. And I've been given permission to go a little bit beyond 1250 since there's a lot of non-students on the call as well. So we'll take another question or two. Thank you. So Dr. Michelle Shang, who's with the Malaria Elimination Initiative, has asked, has your lab considered other methods of delivery treatments such as the use of drones?
I think that's a good question. I responded to the cholera outbreak in post-earthquake Nepal, and we debated pulling samples off the mountains by drone. And I just kept imagining like a drone crashing into a lake with cholera in it on its way to our hospital. And we were in a debate between helicopter, drone, or person on foot. And the most durable mechanism was person on foot. But I do like to think about where are we going to be at 10 or 20 years? And once we get into that kind of future mindset, it does make sense. we can't get samples from the eastern part of Haiti to a shipping station in Port-au-Prince because of the violence. And using a drone in that situation, even now, might be reasonable. So I'm open to technology, but I always want to make sure that it's not a solution that's looking for a problem, but rather a problem that's looking for a solution.
Well said. Thank you so much. And I want to go back to Maha. Do you want to, why don't you pose the next question that you had? I think many will be interested in Dr. Nelson's response to that.
Yeah, sure. My last question, which is something actually you touched on, but what, with regards to the current lack of guidelines for pediatric telemedicine, how can you comment on how you're working to fill that gap and how you can contribute to high quality evidence-based and scalable guidelines?
Yeah, I think one of our best assets is at times being a bit naive. When we started this, I didn't realize just how much of a problem it was that there wasn't a clinical guideline for the space. And I thought that simply deriving a guideline off of the IMCI WHO guidelines would be easy, but it definitely wasn't. And I had this kind of overwhelming sense of we're going to fail. And then I got on a call with a group that you may know called ThinkMD. And they really challenged me to think outside the box and say, look, it may be possible that a parent can put their hand on a child's chest and count their heart rate. It may be possible that if you provide a 15-second window for counting, that they can do respirations. So we began thinking more radically about what a parent without a medical education could do via flip phone at nighttime with a flashlight. And it's those paired data between call center and bedside that have allowed us to kind of toss the bad ones, keep the good ones, particularly look at the negative predictive value of some of these clinical criteria, and shape a new guideline. We're writing that manuscript really with the idea of it being delivered to the WHO bulletin, so it could start a conversation of building a group within WHO to think about a telemedicine guideline, because it doesn't just have to be the context that I've spoken in. It can simply be a child that needs insulin, a child that needs their pneumococcal vaccine, and isolation more and more so can be traffic jams. You've been in DACA, you've been stuck in a traffic jam. And so telemedicine has got to be a portal to improve access to care for all pediatric patients.
Excellent. Well, thank you so much. Thanks, Maha, for the great questions. Thanks, Dr. Nelson, so much for this really fascinating talk and fielding our questions. I think there was a lot more of where that came from. Appreciate you offering to jump on Zoom with folks who are interested. I know the MEI has an opportunity to interact with you this afternoon, so we're looking forward to that conversation, and I hope others also reach out to you. So thank you for being here with us, well, virtually, and thanks to everyone for joining in the grand rounds today. We really appreciated you being here. I've been asked to make one additional announcement about a future talk happening on January 19th. IGHS will be hosting Dr. Julio Frank for a talk on the future, and that might be Julio, sorry. Julio Frank for a talk on the future of health professions education, a follow-up to a Lancet Commission report he wrote with Dr. Sepulveda. The talk will be in Rock Hall with virtual access available. Please watch for registration notice. So I think more information to come in your inbox on that. So thanks, Robert, for a heads up on that. Thanks, Robert, as always, for coordinating the grand rounds today and switching us from the room to virtual last minute. So appreciate it. Thank you again, Dr. Nelson. We wish you the best for your time here in San Francisco, and we'll be keenly following the future of MotoMeds. So thanks again, and thanks to everyone. Have a good and hopefully dry afternoon.
Thank you for hosting us. Thanks.